presentation will be on the bone health and non-cardiovascular risks. And I don't have my disclosure slide in here, but my disclosure is that I'm a consultant for almost all of the vendors that work in advanced prostate cancer. And I want to also say that this is low-hanging fruit. So what I'm going to talk about today, this is not complicated stuff. This is stuff that we're all very capable of doing. Many of you are already doing it in your practices. But this is probably about, when we look at comparing this information to what Bob just talked about, this is really pretty easy stuff, and something that we can all do in our practices very easily. So when we look at a normal bone loss on the right, you can see that for normal men, that's about 0.5% rate of bone loss at 1 year, and these are for just normal men. And then women, you can see, is slightly higher. But for men who have non-metastatic prostate cancer who are on ADT, it's roughly 4.6% greater risk of bone loss. So it's a real deal. And then when we look at fracture risk, we can show that for men that are not receiving ADT who have prostate cancer versus those that are receiving ADT, the relative risk difference here is about 54%. So there is a significant rise in fracture risk in men who are on androgen deprivation therapy. So how does this mechanism work? So when we give ADT, we see a decline in sex hormone levels, specifically testosterone. And when that hormone level drops, then we see this increase in rank ligand production in that bone microenvironment. What that rank ligand does is it acts to promote formation, function, and survival of those bone-resorbing osteoclasts. Remember, the osteoblasts will build up bone, the osteoclasts will cause bone resorption. So that increased rank ligand results in an increased resorption of bone. And that will lead to excessive resorption, resulting in bone loss and risk of fracture. And that's really the mechanism that we see occurring in men who are on ADT, or for any men that have reduced levels of testosterone. So how do we monitor for bone loss? So the most common way to do this is with a DEXA scan, the dual energy X-ray absorptiometry. And this is easy to do. The recommendation is at the initiation of therapy or shortly after the initiation of ADT. And the recommendation is to do this about every 2 years after you do it at baseline. We've gotten the habit of this in our advanced prostate cancer clinics. It's essentially part of our standard protocol. As soon as a man gets started on ADT, immediately gets a baseline DEXA scan, and we monitor along the way. I've actually never seen a DEXA scanner. I've ordered hundreds and hundreds of them, but I pulled up a picture of it just to show you. It's a pretty benign appearing apparatus. It's not scary looking at all. There's no injections required. You basically lay under the camera and it takes a bunch of pictures. And the results are, for a normal, you'll see a T-score of -1 or higher, and they'll say that that's a normal bone score. And then for osteopenia, you can see a T-score anywhere between -1.1 and -2.4, and with osteoporosis over here on the right, -2.5 or lower. And that's how they're read out. You'll also get a FRAX score if the bone density is abnormal. Now, if the bone density is normal, they won't report a FRAX score, but this is a fracture risk assessment tool, and it basically estimates the risk of hip or other major fracture in the next 10 years. To get an accurate FRAX score, the patient actually has to fill out a questionnaire when they go for their DEXA scan. It takes into account multiple factors: their age, their lifestyle issues, comorbidities, and it also incorporates that DEXA score in there. And if it's an increased fracture risk if that score is greater than 3% for a hip fracture or greater than 20% for other major fracture. And it's recommended that anti-resorptive therapy should be used in men with prostate cancer who fit into that above category who are at increased fracture risk. So this bone loss mitigation and maintaining optimal bone health is really a group of 3 areas that we put together. And again, this is not rocket science. These are things that are very, very easy to do. But unfortunately, sometimes the simplest things are left undone. And so we have lifestyle and activity changes, you've got supplements that can be used, and then anti-resorptive therapy. So the lifestyle and activities, I tell all of my patients they should be doing weight-bearing exercises, and what we usually ask them to do is that they don't need to go out and buy 100-pound dumbbells, but even just 5-pound weights to work on their arms and to do their walking, jogging, stair climbing, weight and resistance training. Yoga is very, very good. Pilates, whatever it takes to get them active. And then, of course, stop smoking, and this isn't just necessarily the case for patients with advanced prostate cancer, but nobody should be smoking anyway, but it is detrimental to the bone health and their overall health. Reducing alcohol is important for two reasons. One is that excessive alcohol can reduce the calcium absorption, but probably even more important, when you get drunk, you tend to fall, and falling is not good. Falling is not good when you're old and feeble, and of course, when you've been on ADT, it increases your fracture risk even more. And then when you look at these newer androgen pathway inhibitors, the androgen receptor blockers, in all of those studies there was increased risks of falls and fractures, so you definitely don't want these patients to be drinking. What about supplements? So everybody should be taking calcium. The total intake should be about at least 1,200 milligrams per day. Ideally from a calcium-rich diet, but most people can't do that alone with their diet, and it requires additional supplementation. Vitamin D3, at least 1,000 international units per day. I live in Florida, and I take 5,000 units of vitamin D every day, and my vitamin D level is 35. Okay, but now people in Florida generally don't go outside. Only the tourists come to Florida to go outside. But if we do go outside, we generally stay out of the sun anyway. But still, it just goes to show you how difficult it can be to raise vitamin D levels above that threshold of 30. So be aggressive with that. And then anti-resorptive therapy. There's oral options, which we'll talk about here in a second, the weekly oral alendronate. You've got the IV zoledronic acid, and this is going to be for patients with ADT that are basically for prophylaxis. And then sub-Q denosumab, which I think for most of us is the most common utilization. So alendronate is Fosamax and risendronate is Actonel. These are bisphosphonates. They do inhibit those osteoclasts from performing bone resorption. You can do a weekly oral dose. There's a monthly dose that you can use. And most of the side effects here are GI related. The reflux, nausea, constipation, diarrhea, joint pain, but most patients tolerate them well. Zoledronic acid you may be more familiar with Zometa and Reclast. This is IV bisphosphonate, and as a prophylaxis, it's just given once a year for up to 3 to 5 years. Similar set of side effects you can see there listed. And then for men with bone metastasis, the zoledronate or Zometa can be given every month or every 3 months. In general, these bisphosphonates, they've been shown to increase bone mineral density, but there's really very limited data to show reduction in fractures and skeletal-related events. So this is where the denosumab comes in and is a little bit more helpful. So you're familiar with Prolia and Xgeva. The Prolia is the 60 milligrams every 6 months for men at high risk for fracture who are on ADT. These are for non-metastatic patients. And then for the metastatic patients, we can use Xgeva, which is 120 milligrams monthly. These are rank ligand inhibitors, so they reduce that activity of those bone-resorbing osteoclasts. This big side effect is, the most common one actually is osteonecrosis of the jaw. This is where urologist actually has to take that extra step and look in the patient's mouth. I know it's hard to do it, but we need to look at their teeth. In Florida where I work, the tattoo to teeth ratio is about 5 to 1. And so you have to take that into account when you're looking at their teeth. But I like to ask them, do you have any rotten teeth in your mouth? And most of them will say, yeah, there's a few there, and we'll hold off on denosumab until that gets fixed. So there's a lot of importance in the good oral hygiene. So Prolia has been shown to reduce new vertebral fracture. You can see at 1 year, 2 years, and 3 years, significant reduction in patients developing new fractures. So we do have some data on that. And with Xgeva, also some significant, almost 20% risk reduction in first bone complication. And this is with an active comparator in this particular trial. So the top line is the Xgeva, and the bottom line is zoledronic acid, which is a very good active comparator. So take that into account when you compare them. All right, in the last minute, I just want to talk about the non-cardiovascular side effects of ADT. And again, this is very low-hanging fruit: sexual health, lifestyle and behavioral health, psychological health. And on the sexual health, sex function, it's inherent with ADT. You're going to have significant decline But it isn't just that sexual decline. You're going to get the lack of desire, orgasm. All of my patients tell me that their testicles and their penis has shrunk, and it's a big deal for them. They really don't like it. So they get these body changes, and you need to set realistic expectations for them and encourage them to use other forms of intimacy and encourage that open communication. Tell them it's normal, that this is not an unexpected side effect, and that you have to have a balance in what you're doing. And for those inclined to consider sexual aids, and there are some patients that can benefit from intracavernosal injections and penile implants. On the psychological side, if advanced prostate cancer isn't enough, now you're going to add the anxiety, depression associated with just being on ADT, and you need to assess this. And there's validated questionnaires that you can use in this department. And you don't want to ignore these signs, and it's important. I always like to talk to the family members. You never get the straight story from the patient. I always encourage the spouse, the family member, daughter, son, significant other to come with them and tell me what's really going on. And then finally, the lifestyle and behavioral issues. The ADT is associated with increased body fat percentage, a lot of body changes that occur with it. Stress the importance of that aerobic activity and resistance training. It goes a long way, not only for how they look, but how they feel. It helps them sleep better. All of these are very important. Consider referral to an exercise physiology program. And then the nutrition. Many of you have heard Mark Moyet speak about the importance of this, but the Mediterranean diet, fruits, vegetables, and to stay away from all the bad things on the bottom line there. And they're bad for you anyway, but especially patients with advanced prostate cancer. So I think the moral of the story here, and you can use this as a quote from me, Dave, is that it's not just about the PSA, that taking care of advanced prostate cancer patients in this PC360 concept is about the whole patient. Patients tend to focus on the PSA, but we really need to be sure that we focus on everything else as well. So I'm going to stop at that point.